And I want to just start off by acknowledging that I'm chairing this meeting or this webinar from the lands of the Darug and the Guringai people, who are the traditional custodians of the land where I work, and I pay respects to their elders past, present, and future. I just want to thank both of my speakers today. We have Associate Professor Gillian Farrell and Associate Professor Susan Neuhaus. And I'm really glad that they both agreed to talk to us today. We're going to start off with Associate Professor Gillian Farrell, who is the head of plastic surgery at the Royal Darwin Hospital. She's an Associate Professor of Monash University in the Department of Public Health and Preventative Medicine. She's a member of the Research Committee of the Australian Breast Device Registry and is on the board of directors of Avant Mutual and the Doctors Health Fund. She's been a great supporter of women in surgery, and she founded the Women in Plastic Surgery group to provide female plastic surgeons support and mentoring opportunities. She's also been committed to improving health outcomes in disadvantaged communities through her current work in Darwin, where she oversees the Darwin Project, which is about workforce project, which is about getting plastic surgeons to the Northern Territory. She's always been involved with work to help the disadvantaged, with working with Interplast, where she did outreach programs in Fiji and Pacific Islands. I think that she's an outstanding plastic surgeon, an outstanding female surgeon, and I'm so pleased that she could come and join us today. So thank you so much, Gillian.
Okay, I think I've pressed all the right buttons. Thank you, Pecky, for that kind introduction. And I'm very honoured to be asked to be giving this talk tonight. I have looked at quite a few of the other webinars, and they've all been very impressive. So I am very pleased to be selected. I'd like to initially acknowledge that I'd like to start this talk by acknowledging that I live and work Wurundjeri land in Victoria, as well as Zarakia land in the Northern Territory. And I work with Aboriginal and Torres Strait Islander people in the top end. I recognise the traditional elders past, present and emerging, and acknowledge that sovereignty was never ceded in Australia. Oops. I do have a conflict of interest to declare, and that I have a conscious and probably an unconscious bias towards women in surgery. And all women in medicine, in fact, because I always see women doctors when I need to see a doctor, and I tend to refer patients to other women as well. However, I have had wonderful male mentors and would not be here where I am today without their support. So my career overview, I graduated a very long time in 1978 from Melbourne University. And then I was accepted into plastic surgery training and completed my training in Melbourne also in 1987. So as most people did then, when we finished our surgical training, I went overseas to work. But I did want to do some slightly unusual things. And I worked in India, in Madras, which is now Chennai, in a hand surgery unit in Stanley Hospital. I then went to Bordeaux in France, where I was a chef de clinique, which is a senior registrar, and learned to speak very bad surgical French. But that was a big challenge for me because nobody spoke English at all at that time. Then my partner and I were in the UK for a couple of years. The first year I was a senior registrar at Mount Vernon, where I did general plastics and a lot of burns. And then on the way back to Australia, we both worked in Malaysia on the northeast in Kelantan, which is on the border of Thailand and Malaysia. And that was for a new university hospital up there. And my job was to set up a burns unit. I then came back to Melbourne in 1990 and started practice as a plastic surgeon. I had 3 public hospital appointments like most people did in those days. And I also set up private practice. In 93 to 98, I had 4 children, and I managed to work through most of that time. In 2003, we decided that we needed a bit of a change, and we uprooted our family to Fiji for a year. And that was pretty challenging. I'll talk about that more a bit later, but it was absolutely fantastic. And I guess it's worth taking a risk like that if you do get the opportunity. When I came back from Fiji, I gave up my public hospital jobs because I was pretty busy with the family and the private practice, and I concentrated on reconstructive breast surgery, which I really enjoyed. I loved having women patients with breast cancer that I sort of related to really well, and I could keep the timing under control, so I wasn't up at night every night. In 2017, Angela Webb, who's the head of Peter MacCallum Cancer Centre Plastic Surgery, invited me back to the hospital to work in breast reconstruction and skin cancers. And in 2021, I can't see it on my screen, in 2021, at the age of 65, I decided to retire from private practice, thinking that I was going to have a quieter life, but that's actually not what has happened. So from a leadership point of view, I was on the Australian Society of Plastic Surgeons Council for 7 years. I was the clinical lead of Australian Breast Device Registry, or one of the clinical leads, for 5 years. In 2019, I was elected to the Avant Mutual Board, and I'm still on because we were had an election last year and I was re-elected for another 4 years. In 2021, I started visiting Darwin as a visiting plastic surgeon. And then in 2022, I was appointed as head of plastic surgery in the Northern Territory. I'm an associate professor at Monash University, and I can't read what's on the bottom. Doesn't matter. So what was I going to talk about? Well, COBI's circles of concern and influence you may all have heard of before, but this is something new to me. And then I just thought I'd talk about 4 different areas where I think I have had some influence and some leadership. So COBI's circles of concern and influence, a friend of mine asked me when I was preparing this talk, she said, have you ever heard of this? And I thought, no, I haven't, but I better look into it. And it's a book by Stephen Covey that was written in 1989. And he really, I think it's called The 7 Habits of Very Influential People or something. And he talks about the circle of concern and the circle of influence. So this is the title of the book, Highly Effective People. The first circle, the circle of concern, is the stuff that we sort of deal with every day, like the big picture stuff, the global pandemic, the state of the economy, the small pictures, the clothes your children want to wear, societal attitudes, all things that you can't change or you can minimally change. So they're really outside your influence. If you devote too much energy to them, they may be a waste of time. And this time and energy once spent can't be reused. So Stephen Covey talks about people who concentrate on their circle of concern as reactive people and feels that the negative energy created by that reduces your circle of influence. So the other circle is the circle of influence, which is inherently smaller than the circle of concern, but it includes the things we can do something about. And the key is to focus your energy on things that you can influence. This will enable you to make effective changes and the circle of influence will increase. Knowing how far your circle of influence extends is important. So is forming partnerships and alliances. You may not have any direct influence over something in your circle of concern, but you may know other people who do. And as leaders, we all know that a team can have a wider circle than an individual. Reactive people find their circle of influence shrinks, while proactive people find that it increases. Proactive people focus on what they can do and can influence. And I guess that made me really think about the reasons that I've done what I've done and why I concentrated on these particular things, because hopefully these are the areas that I have actually had a circle of influence and have managed to make a difference. And I think as leaders, that's really our responsibility to always feel about making something better or contributing in a positive way in whatever we do. So how did I get involved with the Australian Society of Plastic Surgeons Council? Well, I guess it sort of started with the panel pledge, which a lot of organisations have signed now, and it's excellent. And the FRACS signed it in 2017, and it comes in various forms, but this one is pretty simple, and it just states that we pledge to increase the visibility and contribution of women leaders in public and professional forums. And that's a very important principle. But you'll notice that these photographs were all taken after 2017. And I think it just indicates that it takes a long time before these changes or intended changes actually happen. And it requires us to be active rather than reactive. So we need to be proactive about introducing the pledge into our daily life. Just a bit of history. I started going to these surgical meetings in the 1980s when I was training as a plastic surgeon. And naturally, I was one of the very few women that at these conferences. And I remember being struck that every time I went to a talk, the speakers were male and the panels were male. And what was interesting is it wasn't just the academic side, because socially it was also really important, because the men went to these conferences and then they'd go to the conference the next year or in another place, and they'd meet up again and they'd form these friendships. So they had all these buddies that they would catch up with in their surgical meetings, and their wives would all become friends as well. And then they organised dinners, where all the couples would go out together. And there I was at the conference by myself, and nobody ever asked me to join them for dinner. So it was just, I guess that was, I'll talk about it later, but that was why I sort of set up WIPS, because I thought we needed our own social group. So you do find that there are, not so much now, but there are all-male boards that when you try and discuss with the members, well, why don't you have any women? They say, well, we've tried to get women on the board, but they're just not interested. And, if they don't want to do it, well, then we're not going to push them. But that's sort of like a simple way of looking at it. But I think women will want to be on if they're invited and they're made to feel welcome, and if they're not too much of a minority. So in 2015, I'd sort of done a bit of research and discovered that the council, the ASPS council or board, whatever you'd like to call it, had 12 members and they were all male. There was one trainee rep who was female, and the training board also was all male. And I'd sort of been reading a bit about this, these targets that the companies were setting for having 30% of women on boards. And I suggested in this email that perhaps ASPS should think about this. There was a number of plastic surgery trainees by that time, and we had a lot of female patients. So, maybe the women should be a bit more involved with the governance of ASPS. And I knew there was a board meeting a week later, so I sort of suggested to Hugh that perhaps they might discuss this issue as a topic at the board meeting. That was on the 15th of August. So interestingly, the next day I received an email back from Hugh, basically saying that they discussed my email and they were going to adopt all of my suggestions, which involved co-opting women and encouraging women to stand for election. And I was pretty happy about that, really, because he also thanked me for stimulating the discussion. So I suppose I felt that my circle of influence, I didn't know about circles of influence then, but I think that's a good thing that happened. So I then went on a bit of a recruitment drive, because Hugh immediately co-opted me to council, which I was very pleased about, but I didn't have much experience in that area. And I didn't want to be the only one anyway, the only woman. So the recruitment ended up a tap on the shoulder, which is, I think, how guys tend to get on these committees and boards. And my version of a tap on the shoulder was a telephone call. But I did realise that the tap on the shoulder often selected people that were very like the person doing the tapping. So it might be someone who wore the same tie or went to the same school or had the same hobbies or the same upbringing, and that this really is unconscious bias, and that I could be guilty of that as well. So when I was ringing women, yes, I was biased towards women, but I wanted to try and make sure I encouraged women of all different backgrounds to get involved on the council. And I sort of made an effort to actively seek out people who were different from me, who were in different fields in plastic surgery or in more public than private. Or anyway, what usually happened is that I would ring them and they would be really generous and listening to my explanation as to why they should think about doing this, being standing for election. And then they would say, look, I'm really busy and working full time as a surgeon, and my partner is also, or husband is also working really hard and has a full-time job, and I'm the main carer of the children. And I just don't think I can do it at the moment. Maybe ask me in a few years. And then the next morning I would get a phone call from the same surgeon saying, you know what, I've thought about it overnight. I've talked to my family, they're all really encouraging, and I'm going to do it. And I don't remember anyone actually saying no. So I was obviously quite persuasive. So my experience being on this council was that if you're the only woman, that's what they notice about you, that you're a woman on the council. And then once you get the second one, they sort of do still think that, oh, there's 2 women, that's interesting. And then once you get 3, then you stop being looked at as a woman and you're just a new board member. And I think it's important that we recognise that, you know, we don't want to be too much in the minority here. So this is a lovely photograph of the 50 past presidents of ASPS, who were all amazing people who contributed a huge amount to the specialty and were very devoted to it. You might notice there's a few similarities between most of them other than gender. But if you look at the right-hand bottom photograph, it's one of Nicola Dean, who was our first female president of the Australian Society of Plastic Surgeons, and she's just finished her term of 2 years. And I'm very proud to say that she was one of the ones who I tapped on the shoulder and who originally said no. So this was the council earlier this year, and you can see that it's pretty diverse. There's plenty of women, there's different ages and different races and different types of practice, and I think it's a great council and just functions incredibly well. So I guess that's something that I feel that my circle of influence did have a bit of an effect. So as leaders, I would encourage you to think about what you're going to do in the way of leadership and which things you could have the most effect on. So what about surgery as a career? Well, I think most of the people listening are already surgeons or well on the way, or maybe would like to be surgeons, but I think surgery is a great career. And is everyone welcome? Yes, they are. Everyone is welcome. The only problem is, do we need to make a new doorway for the women because they're not going to fit in this one? Or do we change ourselves in order to fit through the door? And I think that's what women have done for years, that they've sort of tried to turn themselves into men in a way to become successful surgeons. But I think we actually need to think about changing surgery as well. And we need to make the door bigger and more inclusive, so it includes all genders. So just look at the numbers. This is in 2022. The vast majority of specialists in Australia are male, particularly in the surgical type professions. If you look at the palliative care, paediatrics, ONG is not bad, but surgery is almost at the bottom. You know, there's only 15% of surgeons are female. If you look at the different specialties, plastics is, you know, sort of in the middle really as far as the ratio goes, but there's still the vast majority of surgeons are male. Of the trainees, this is from 2020, so it's got better since then. But, you know, it's sort of quite slow and we've still got a fair way to go. This is over 15 years. And I must thank Christine Lai for those slides because she gave a fantastic talk at the FRACS Tri-State meeting in Broome, and I was very impressed with these figures, and I did borrow her slides. Thank you, Christine. So why does it matter? Well, a lot of people say to me, why does it matter if most surgeons are male? I mean, surely they're much better suited to the specialty than women are. But you know what? I don't think that's right. I think patients like to have a choice of gender when they come to choosing their surgeon. And certainly in the NT, plenty of women leave the Northern Territory because there aren't any female surgeons there. We provide diversity of thought and approach within surgery. It's true that female surgeons have fewer complaints from patients, and that's been proven. Some patients would have cultural limitations that prevent them from attending a male surgeon, and we certainly have a lot of women that will only see women. And female surgeons have lower complication rates than male surgeons. This was a study that was published, I think, in 2021, yes. And they looked at 1.3 million patients and found that the complication rates for female patients who are being operated on by male surgeons was much higher than for female patients being operated by female surgeons, as was the death rate. So I guess the answer to that is yes, we do need more women in surgery. So the next thing I wanted to talk about, which Pecky mentioned, was that I did set up this group called Women in Plastic Surgery. And this happened at about the same time that I was trying to recruit people to be on the council. And I sort of did it for selfish reasons in a way, because I wanted to have my own buddies in plastic surgery. And I liked the idea of meeting women of sort of all different ages and different interests in a setting that was without sort of tension, if you like. So this is the sort of logo, if you like, just because Women in Plastic Surgery stands for WIPs, and every time I did an invitation for a dinner, I would put a different lady holding a WIP. So it's primarily a social group consisting of female plastic surgeons and trainees, and you're automatically a member if you are a woman and a plastic surgeon or trainee in Australia or New Zealand, or you're one of our visiting speakers, international speakers, who is a female plastic surgeon. And we tend to have these dinners associated with a meeting, such as the Aspen meeting or the FRACS meeting. And that means we get more attendees and people from interstate can catch up. Sometimes we have speakers. They could be medical or non-medical, but they're always inspiring. And we're independent. That is, we don't have sponsors and we pay our own way, and we don't pay the speakers. So this is some photographs from our dinners starting from 2015 up to 2022. We obviously had a gap during COVID, but we've tried to maintain regular dinners since then. And they're always a lot of fun. And that's the way I can describe them. I really, really enjoy them. And we have some really good speakers, really impressive people that I think are inspiring for all of us. So this was the last dinner that was in October last year in Brisbane. And the best thing for me about this dinner, well, not really the best thing because I loved it, was that I had nothing to do with organising it. So I now feel that I can sort of not walk away from it, but I can leave it in the hands of the younger women to continue this, this group. And I really enjoy it myself, and I hope the other attendees do as well. There's obviously some people that aren't supportive. You know, some of the guys are quite critical, think we shouldn't have such an exclusive group. Some of the women feel that we don't need it and we shouldn't be making ourselves exclusive. But I think you can see by the number of attendees that most people enjoy it. So again, I suppose I could say that this was somewhere that I had some influence in getting together women that wouldn't spend a lot of time together normally, but just a good chance to chat. So the next topic is a big one. It's Royal Darwin Hospital and the rest of the NT. Now, these photographs are just beautiful pictures of the Northern Territory, and I hope they encourage you to visit if you haven't been before, or even think about coming to work there for a brief time, or to come and work and live there permanently. It's a great place to bring up kids, and as long as you don't mind the weather being hot, it's fantastic. So the Aspen Darwin Workforce Project, I just wanted to show you this photograph of the hospital. This is Royal Darwin Hospital on the left, and this is a new Indigenous mural that was almost completed when this photograph was taken, and it's absolutely beautiful. So how did the Darwin workforce start? Well, in 2019, there were really virtually no plastic surgeons in Darwin. There was one who worked at the hospital and still does, but that was 0.1 EFT. And there was a set trainee in 2017, but they did not have enough support. There weren't enough consultants, and they were completely burnt out. So the board came and inspected the hospital and immediately removed the trainee. So we had a lot to do to try and get a trainee back, but that's another story. But this was all started by Nicola Dean, who then became president of ASPS, and in conjunction with the Top End Health Service and Royal Darwin. And her plan was to have 2 VMOs from anywhere in Australia who would come for any period of period of time they liked. And it's been going since August 2020. It was meant to be from 2020 to 22. It was a 2-year program, but it's still continuing. Oops. I don't know how to get rid of that. I might need some help with this. I don't know how to get rid of that screen.
We can still see your slides properly, Gillian,
I
without
can't.
any
Getting rid of
issues.
this one. I've got something else that's popped up. That's all right. So these are photographs of the various teams that have been there, and that they're not really teams to start with because they're plastic surgeons from anywhere, and most of them don't know each other that well when they work together. And I have to say they collaborate incredibly well. It's a really cohesive team, and we have people from all over the place, as were our registrars initially. Most of them came from overseas because that was all organised by the Director of Surgery. And we've more recently had more local people being our registrars, but it always works really well. So I became head of unit in 2022. Prior to that, it was the head of the Department of General Surgery that was the head of our unit, and he really didn't have the time or the interest particularly to expand us. So we really needed a leader, and have to be honest, nobody else said they'd do it. So I said I would. And I really enjoyed it. It's a huge challenge, and it's certainly not all within my circle of influence, but I do think I've made some progress. So I'm the head of the unit and I work remotely and in Darwin. So I go to Darwin quite frequently, maybe average a week a month. And I'm in Melbourne the rest of the time, where I do 1 day a week for Darwin. And I also work at Peter Mac and at the Breast Device Registry and the Avant board. And so I'm quite busy. We've got quite a few plastic surgeons now. We've got Mona, who's Palestinian from Dubai, who's excellent, but she hasn't done the training in Australia. Mark Moore's a craniofacial surgeon who visits 3 times a year to do cleft palates. We still have one VMO coming all the time, and we've got a beautiful apartment for them to stay in. We've got Shabad Ramdas, who was at IMG, an SIMG, but he's passed his exam and he's finished his FRACS, so now he's a locally trained FRACS surgeon. We've got a new IMG who's from the UK, and he's been judged as being substantially comparable, so he will get his FRACS hopefully in a year or so when he's got his logbook full enough. And then we've got Ravi Mahajani, who's the private practitioner who comes and does 0.1 EFT with us and does a lot of the outreach work. I'm really proud to say that we've recently found out that we have a set trainee for next year, which is absolutely fantastic. We missed out last year, and understandably, the board wants to make sure that we're a very stable unit, and that's what I've tried to produce. So we now have 3 service registrars, and we will be having a set trainee. We've also got permission to have an intern as long as we get enough applicants to be interns next year, which is always a problem. We've got 2 junior residents at the moment, and next year we're going to have a senior resident, which is a 12-month job in plastics. And we've now got 2 charge nurses who are amazing, one in theatre and one in the ward in the clinic, who look after plastics solely. So what do we do? Well, you can see that we're pretty busy. We have about 40 admissions a week. There was a real peak in 21, and I think it's because half of Australia came to live in Darwin to escape COVID and lockdowns. And we've now built up again. You know, we could do more than that if we could get more operating time. So our electives are very limited by the number of elective lists we get, and we're very short of nurses. But yeah, it's a very busy unit. What do we do? Mainly emergencies, about 20% elective. We have the majority of our patients are Aboriginal and Torres Strait Islanders, about 50% from the remote Aboriginal communities. And it's important to know that English is not their primary language. There's about more than 100 different languages spoken amongst the Indigenous communities in the NT. We see a lot of complex infections, including necrotizing fasciitis and Fournier's gangrene, and they will always seem to be referred to plastics. We do lots of hand fractures. We do hand fractures every day. Straightforward ones, compound ones. I mean, we get lots of hand infections such as tenosynovitis and septic arthritis. We do get a lot of animal injuries, which I've never seen before. And I've seen all of these and more. And we're now starting to do a lot of burns. I think the general surgeons would be quite happy if we took over the majority of the burns, but we have to send away anything more than 20% body surface area. And we certainly assist as much as we can with looking after the others. So what have we done more recently? We're now doing much more complicated cases. We do head and neck reconstruction with the ENT surgeons, which is often a free flap. We do lower limb reconstructions with orthopedics, again, free flaps for compound fractures. We've done 6 DF breast reconstructions now that have all been successful. We do a lot of skin cancers, as you might imagine. We don't do much purely elective plastics such as breast reduction and abdominoplasties because we just don't have the operating time, but the demand is there. And we do a lot of elective hand surgery, and we have great hand therapy support. So this is a photograph from the first DF that was done in Darwin, and you can see that the gender diversity of the surgeons is perfect. This is just some typical patients, an old fellow with a SCC on his nose, an unfortunate fellow who got a fish hook in the wrong place, a woman who had 2 pet dogs that mauled her while she was asleep and ended up losing both her arms, a typical hand fracture, a crocodile attack that ended up on the front of the NT News, and this guy was very happy to be photographed and demonstrate because he got away from the crocodile, which doesn't usually happen. And a climber who was accidentally dropped by his buddy and sustained a nasty fractured tib and fib and needed a free flap. We use a lot of BTM there to prepare the bed for grafting, and I do unfortunately see a lot of assaults. This is a fellow with Gorlin syndrome. You probably know it's congenital disorder which has multiple BCCs, and Darwin's not a good place to live really for someone with that. We do see a lot of maggots that are quite useful for debriding wounds, but ultimately we actually need to do that ourselves. We do see quite bad hand fractures that tend to present late, and this was an interesting case done by Nicola Dean for a stenosis of a tracheostomy. That's a DP flap, deltopectoral flap. And interestingly, this was the first hand replant that I'd seen, but this was a guy who had his hand chopped off and also had his scalp, was nearly scalped with a machete, and this happened a long way away, and the hand was sort of left in the sun for a bit, and then somebody thought, well, perhaps the hand could be put back on. So they got a care flight and sent the guy up to Darwin with the hand in a plastic, and the team replanted the hand, which was fantastic. It took about 12 hours, and this is in a 60-year-old man who's a smoker. So that's really been a good success, and he does have reasonable function. So the rewards are many. There's an enormous need for a plastic surgery service, and it's really good to be needed, you know. The local surgeons and nursing staff are supportive because they realise that we're doing a lot of good work there, and it's a fantastic experience for the registrars and residents, and I'd certainly encourage any of you who get the opportunity to work in Darwin to take it. I think we are saving a bit of money for the healthcare system because we're doing stuff in Darwin that used to previously been sent interstate, and we are doing outreach as well. And we certainly have had strong support from the government, the Chief Medical Officer and the Minister for Health, the previous Minister for Health, who was also the Chief Minister of the Northern Territory. There are a lot of challenges, and I have to say that most of these are outside my circle of influence, unfortunately. But, you know, a lot of the patients have multiple comorbidities. They present late because they're so far away and they don't want to come to the hospital. They take their own leave because we can't get their operations done quickly enough, and the hospital's freezing, and they need to go back to their own communities, or they have sorry business, and so they leave and then tend to come back a few days later. There are communication challenges, both language and cultural, and transport's always a problem because we have to use a lot of care flights that are very expensive, but there is the Greyhound bus, but not for most areas. There is, unfortunately, quite a lot of domestic violence and alcohol abuse. And because of the diabetes and renal failure and poor nutrition, there's a high infection risk. The environment is also challenging. The build-up is the time between the dry season and the wet season when it gets incredibly humid and everybody becomes extremely irritable, which leads to increase in domestic violence and street violence. We also have a lot of dangerous animals around. Unfortunately, our motor vehicle accidents have the highest mortality rate in the country. The e-scooters are normally ridden by tourists who are drunk wearing thongs, and that combination is without a helmet, and that combination is very bad for us. Territory Day is the one day of the year when you can set off fireworks and there's no limit. So you can go and buy fireworks from every shop in Darwin that sells them just for 24 hours. And then it's a really scary night when there's fireworks going all night. The challenge is also the hospital, which is too small. It's the same size as it was when it was built 25 years ago, and everybody's double bunked in every ward and theatre and emergency department, and we don't have enough theatre. So what can we do to improve the situation? Well, we can certainly increase the cultural competence and awareness in the surgical staff, and that's something that I'd like to focus on. We need more Indigenous interpreters because they really do provide a bridge between the surgical staff and Indigenous patients. Most of us are foreigners, really, and we just don't really have enough background in the Indigenous culture to understand what's important. So we also really need to concentrate on educating the Aboriginal health workers and supporting them to support their communities. We are increasing our outreach services, and we already go to Catherine and Gove, and we'll be starting to go to Alice Springs soon. And telehealth is essential when you're reviewing patients. So I'd say that the ones in red are things that are really out of my circle of influence, even though I'd love to have some effect. There's an awful lot of dangerous dogs around, and I think the dogs that attack humans should be put down, but that doesn't seem to happen. I do think we need to have a look at enforcing helmet wearing on those e-scooters and have a blood alcohol limit, and we certainly need to ban fireworks. This is one of the remote wound programs that we did a couple of years ago. We went to Bachelor and taught Indigenous health workers how to suture pigs' trotters. We've got a fantastic interpreter service, but as you can see, they're only available from 8:30 till 12:30, Monday to Friday, and we really need them 24 hours a day, 7 days a week. As I said, there's more than 100 languages, but a lot of the interpreters speak several of these, and they also have very good health literacy as well. This is one of our patients on Territory Day 2022, who's unfortunately had a firework blow up in his face, and he's alive, but he's blind. The second replant we did was Territory Day last year. So this guy got the prize for the most spectacular injury last year. He decided to put a firework into a metal pipe, which he thought would direct the firework away from him. But of course, the firework exploded in the middle of the pipe, and the pipe flew straight at him and cut off his hand. So luckily for him, this was in Darwin, and he's had quite a good result from his replant. His operations take 12 hours or so. So interestingly, we have managed to increase the gender diversity in this Department of Surgery in Darwin. We do have a couple of female surgeons who are excellent, but there's been a few that have left because of various unhappiness. But you can see that we've actually doubled the number of surgical women. This is not the current team exactly, but we usually have about 5 or 6 women in our surgical team, plastic surgical team. So as head of the unit, what are my personal goals? I wanted to create a cohesive team, and I think that's happened, is continuing. We need to look at any problems as quickly as we can. And I definitely encourage all the team members to call or email me anytime, even though I'm in Melbourne, and we can talk about issues. I have meetings with the team every Monday and Friday at 7:30 when we do a virtual ward round and talk about the plans for the week and the cases and the difficult cases and complications and the pathology. I'm there as often as I can be, which is probably, as I said, about a week a month. And I need to remind people who I am. I sort of introduce myself around, and it does help to be there, I must say. I tend to introduce myself to the other people around that are important to us as a unit, including the theatre nurses and the people who order the instruments. And, we're always discussing what we need, which we don't usually get. And I have zero tolerance for misogyny, racism and harassment. So the long-term goals, I think we need a permanent head of unit in Darwin, and I don't think it's going to be me. I'm sort of close to retirement. We need to work out how many consultants we need, and I think we need at least 4 full-time and a good range of skills. we still need to have visiting medical officers for complex cases. And, you know, there are things like clefts and some pediatric cases that we probably won't be doing in Darwin. We are establishing more outreach clinics to extend our care. And as I said, we have a set trainee for next year, and I would hope to have 2 in the future. We definitely need to support local medical graduates and Indigenous doctors to become surgeons. So I'm very keen on team building and personal development. So we have quite a few functions. When people leave, you know, we had a cruise and we go out for dinner. And this photograph was taken at the tri-state meeting last year, which was in Darwin. And I asked the registrars to all present something at this meeting, and they submitted abstracts, and 2 of them presented papers and 2 presented posters. So I was very proud of them for doing that, and it's a very good start to getting used to standing up in front of an audience. So what are we doing towards closing the gap? Well, there was a study in 2020 that showed that 3 in 10 Aboriginal and Torres Strait Islander people do not seek a healthcare provider when needed in Australia. And there's lots of reasons for that, but probably the main one is the lack of culturally appropriate healthcare services, lack of respect of cultural values, institutional racism in the healthcare system. So we can all try our best to do something about that. We certainly need more Indigenous doctors. We have 563 Indigenous medical practitioners in Australia, which is 0.4% of the total population, number of medical practitioners. Indigenous Australians make up 3.8% of the population. So if you work it out on the numbers, we need 200 Indigenous surgeons in Australia. So back to the circles of influence and concern. The last thing I was going to talk about briefly is the board work I do. And I think Susan's much better placed to talk about boards. So I just thought I'd briefly explain how I got on the board. I did the ARCD course in 2019, and this was a residential program in Byron Bay, and it was fantastic. So I'd highly recommend it if you're going to be interested in doing board work. And I was the only doctor there, but I met so many interesting people that wanted to extend their level of knowledge and expertise in governance, and I really enjoyed that. So when the opportunity came up to stand for election for Avant, I thought it would be a good board for me to be on, and I was fortunate enough to be successful, and I've just been re-elected for a 2nd term. And being on the Doctors Health Fund Board also is great because I'm a firm believer in the mixture of public and private health in Australia. So our board consists of 12 directors. There's 6 medical directors that are elected, including the chair, and 6 commercially appointed directors. We meet about every 3 months or more frequently if required, and we're all on various committees. There's a lot of reading to do before each meeting, and we get the papers about a week before, so you really have to devote quite a bit of time to reading the papers before the meeting. This is a dinner that we went to last year, and this shows the women who are on the board of Avant. There's 3 of us, our female CEO and the other senior executive people. So the other thing I wanted to talk about briefly was when we went to live in Fiji for a year. Now, this did involve taking a risk, I guess, because we closed our private practices and rented our house out and took the kids out of private school. But it was actually a really formative time for the whole family, and the kids still remember it very well, and they still have lots of connections there, and that will continue, I think. And I think that introduced them to the idea of working in less developed countries, and certainly Darwin, I think, and Northern Territory would qualify for that description. So earlier this year, we went back to Fiji. The whole family went to celebrate the kids' nanny's 70th birthday. And this is our Fijian family. So this was our children's nanny, Louisa. This is one of her grandchildren, and these are all her children and grandchildren and some great-grandchildren. So we were put up on the high table, which was a bit embarrassing, but a great honour. And it was an absolutely fantastic Fijian celebration. This is Louisa in her house, where about 10 of them live, and it's my son, Louisa. And we all went to an island that we used to visit 20 years ago. And it was just an amazing holiday. So when it comes to children, I guess what do we want for them? I think parenting is the leadership role that I have found the most difficult and challenging, and probably the one that I've made the most mistakes in. And I guess that's just what happens when you're a parent. And but at the same time, you know, I think that the kids have all turned out well, and they are happy, healthy, and safe. And I'm also pleased to say that the three girls all live in the Northern Territory now, and they work in education, health, and law. My son is a musician, and we all went to East Arnhem Land recently for a holiday, and he ended up playing with a couple of Indigenous bands, and he wants to continue that collaboration. So I think they all do have quite a well-developed moral compass. They all feel that they need to give back, and I'm very proud of that. And that's all I've got to say. Thank you for listening.
Thank you so much for that, Gillian. That was a fantastic talk. Um, I'm just going to have a little ad break at the moment because we can't have these webinars unless we are supported by our companies. And I just wanted to say a really big thank you to Medtronic, who are supporting this webinar. Oops, and it's gone back to what I didn't want. Oops, I hope that's worked. Good. And so Medtronic have very kindly sponsored this Women in Surgery Leadership webinar series. And as part of that, what they wanted to just bring to everyone's attention is about pelvic venous disorders. And I'm just going to very briefly tell you that this is a common condition that affects millions of women, and they are more likely to talk to you as their female surgeons about their chronic pelvic pain. And if they do mention any of that, and chronic pelvic pain basically describes any conditions caused by pelvic venous hypertension. And there's sort of four things that can cause that. There's gonadal vein reflux or ovarian vein reflux, iliac vein reflux, iliac vein compression, or renal vein compression, which is called nutcracker syndrome. And so these patients will talk about having chronic pelvic pain. It's not usually or can be related to their menstrual period, but can also be there all the time. It's provoked by gravity. They can have pain or discomfort when having sex. It's definitely more common in women, and especially in women who've had multiple children. In pregnancy, they'll get vulval varices, or their varix veins will get much worse. They can get leg swelling, with or without varicose veins. And if they have nutcracker syndrome, they can get left flank pain and left hematuria. And if you do get patients who have these symptoms, please refer them to your friendly vascular surgeons or to anyone else that does interventional work. So once again, that was my little ad. So thank you, Medtronic. And we're going to move on to our second speaker, who is Associate Professor Susan Neuhaus. So she's got an amazing CV as well. So I just want to start off by saying that she's a fellow, obviously, of the Royal Australasian College of Surgeons. She's spent over 3 decades in public and private surgical work and academic practice in Australia and overseas, and she's currently working as a locum surgeon in regional areas of need. She served in the Australian Army, both as in the regular army and also in the reserves. She was deployed to Cambodia, Bougainville, and Afghanistan. She was awarded the Conspicuous Service Cross and retired at the rank of colonel in 2011. She is an author, and she published one of her books that she published was Not for Glory, about female medical practitioners in the Australian Army. And for anyone who was lucky enough to see it, it was actually adapted by the Shift Theatre into a play, which they did at the ASC a few years ago, which lives on in my memory as one of the best things that I ever saw. It was amazing. She is a non-executive director and board chair. She's a fellow in the past, South Australian Northern Territory Divisional President of the Australian Institute of Company Directors. She's a member of the Council of the Australian War Memorial. She's a non-executive director of Aspen Medical, MEGA, and the Defence Health Limited. In 2012, she was a South Australian finalist for Australian of the Year, And in 2020, she was admitted as a member of the Order of Australia for services to medicine and veterans and their families. So again, thank you so much, Susan, for talking. And I have to say, as a woman in surgery, she was the first consultant who organised for there to be a flexible training position in South Australia, which was the first part-time general surgical training position, I believe. So, and that was done by Susan. So thank you so much.
Thanks, Pecky. Thank you for that very generous introduction. And thanks, Gillian. I really enjoyed that presentation. And for everybody else, I'm really sorry. I'm going to appear extremely unprepared because, unlike Gillian, I do not have a PowerPoint. For those of you who may be very observant, you will notice that one of Gillian's colleagues has actually been at my face in the last 48 hours. I came back from Whyalla, where I do guest appearances with a very impressive periorbital abscess, which has been drained and packed. So I didn't think I would ever allow anyone to bring a needle near my face and give me an intraocular or infraorbital block, but it was excruciatingly painful. So I'm not sure I even noticed the local anaesthetic. But look, I am coming from Adelaide, which is the traditional land of the Kaurna people. So I do pay my respects to their elders, past, present, and emerging. Mani nodlu, tapende nodlu, gani yatangaren barendi, gana mayuna yanta yatamatana. Now, you'll all be pleased to know that this is a completely slide-free zone. It's also largely going to be a surgery-free zone because I may have not quite got the correct brief. So what I thought I would do is really just talk through, I guess, my own journey to directorship, spend perhaps a little bit of time talking about what are transferable skills, and then finish up perhaps with some advice for people who are thinking about transitioning away from a surgical career to a slightly different field. So I started my first board role in 2010, so quite a long time ago now, when I was invited to join the board of Cancer Council South Australia. That was, at that time, I really didn't know a great deal about what was involved with boards and fiduciary responsibilities, but I had a fantastic chair and got some really great advice and had brilliant mentors. So for me, two pieces of the best advice. One was to do the AICD course, as Gillian has mentioned, which was very formative in teaching me the skills that were required. And the other was to join the Audit and Risk Committee. And it was put to me that if you want to understand how business operates, then getting yourself on the Audit and Risk Committee is the best way to do that. And even though as a surgeon, that certainly wasn't the natural place for me to sit, I'm very much a words person, not a numbers person, and certainly not a finance person. I did learn an enormous amount from that, and it's been a rule of thumb that I've applied to every board I've been on ever since. So the next board that I was involved with was a medical one. It was the Australasian Sarcoma Study Group, which was very formative as a trials group at that point in time. And then for various reasons, largely related to my past, I was invited to join a board called the REPAP Foundation, which was largely a hospital board, a hospital research board in South Australia. But it was at the last named repatriation hospital in the country. And it was there that I found myself becoming a very accidental chair of a board, and also had some very formative lessons in crisis leadership. Because those of you who can cast your minds back to the centenary of Anzac, that was also the year that the South Australian government decided to close the last standing named repatriation hospital in the country. It was a decision that was incredibly unpopular. It resulted in some 300,000 signatures of protest, and it resulted in protesters spending over 176 days camped on the steps of Parliament. So I found myself inadvertently thrust into the chair role at that particular time, and learnt very rapidly what it was like to be on the wrong side of a parliamentary inquiry, to be giving evidence in Parliament, to be appearing in Hansard, to be appearing in the newspapers. And one of the consequences that came out of that was I found myself chairing a state government advisory panel about a $15 million centre of excellence that was subsequently built. And on the back of that, I just started to end up with more of a board portfolio, which I was running in parallel to my my clinical practice at that time. So, but as Pecky has said, I now have largely transitioned away from surgery. I do guest appearances as a locum in country areas these days, and most of my life is running a portfolio of boards. I was the South Australian president, or South Australian Northern Territory president of the Australian Institute of Company Directors. We've now stood up the Northern Territory as its own division, which I'm extremely proud of. That is well overdue. I think, correct me if I'm wrong, Gillian, but 1924 was the separation of South Australia and the Northern Territory, so it's certainly taken a while. I was also on the national board of the AICD, which I've stepped away from now. So the current boards I'm on are Gillian's opposition, so MEGA, and I'm on the audit risk and clinical and claims committee for that. I serve on Defence Health Limited, which is a private health insurer. And again, I'm on the audit and risk committees of that. Then both of those are regulated, so they're upper regulated boards. As Pecky said, I'm on the Council of the Australian War Memorial. So that's a government board. It's a very privileged position. It's a very interesting governance role because you are at the table with the Chiefs of Army, the Chief of Air Force, the Chief of Navy, former Prime Ministers, former ambassadors, and it is just an absolutely staggering board to serve on. I chair the redevelopment committee, which perhaps doesn't seem like a natural skill set of a surgeon, but is a $500+ million redevelopment that's being done at the moment, including Australia's largest, or actually it's in the Southern Hemisphere's largest geothermal installation. So quite a different headspace to surgery. In a slightly more medical vein, I'm on the board of Aspen, which is a global healthcare provider, and interestingly has taken over the management and running of the hospital that Gillian was at in Fiji. So that's Lautoka Hospital. And I have a great little charity board, which is Camp Quality, which I'm sure some of you will know, provides puppets and respite for kids with cancer, which is just an absolute joy to be on. So why this? And how would a surgeon naturally fit into this world? Well, I guess I've given that a little bit of thought in terms of what are transferable skills. I think people will often look at doctors and say, well, how could you possibly be a board director? But in fact, many of the skills are remarkably similar. So I think as surgeons particularly, we're really good at coming to a diagnosis. We're good at bringing perspective. I think we inherently have a very good perspective and understanding of risk, because risk is something we deal with every day. And that's obviously, you know, risk with some sometimes very severe or fatal consequences. So I think we do have a good perspective and a lens on those things. I think surgery also teaches you to be able to deal with people who are vulnerable, which is very important when you're working in the not-for-profit space. But also I think that EQ, which is about understanding what are the questions that haven't been asked. You know, what is the question that someone's desperately about to bring out perhaps as they're leaving the room, or the question that's gone unanswered. And that curiosity, that I guess intellectual rigor with which we approach the world is very much the same as the skill set that you bring on board as a director into the boardroom. So what would I say to people that are interested in having a board career? Well, I think you do have to start very early. It doesn't sort of come to you. People will often think that they'll reach a stage in their career and suddenly doors of opportunity will open. I think that's not the case. It's particularly not the case these days. It may have been the case historically. So you do need to start early. You do need to hone your director skills. So you need to attend courses and get your director CPD up in the same way that you would get your surgical CPD up as well. I think it's important for people to understand not to confuse the roles of advisory boards and chairing advisory boards with fiduciary responsibilities of a director, because they are quite different and quite distinct. I have had brilliant opportunities to be on boards, to meet the most amazing people, as I have through my surgical career. And it has been an absolute, sincere privilege to be able to do that. I guess my only caution would be that boards or surgeons are inherently doing people. We are decisive people. We see problem, we solve problem, we move on to next problem. Perhaps linking back to Gillian's presentation, board roles are not really about doing, they're much more about influencing. So board roles are about being able to step back from that and say, how can I shape the decision-making? How can I bring my skills and experience to bear here? What are the unique perspectives that I can bring that add value to the table? And how do I enable the doers and step back and get out of their way to let them get on with the doing? So quite a different role from actually, I suppose, our natural sweet spot of going in and fixing problems. So that was really all I had to share, but I am more than happy to take questions from people, because I think that would probably be more constructive. So thank you.
Thank you so much. And I have to say, when Gillian was talking about women in surgery and things, I have to say to everyone that when I joined on, Susan's red lipstick made me very jealous. So I had to quickly go and grab my lipstick out of my bag and put it on. It's not as red as hers, and I was just actually thinking when Gillian was presenting, and I thought, well, it's something that I would never think to do in a meeting with male surgeons, is fix my lipstick. So there you go. I just wanted to ask, I'm going to start off by asking, in terms of the AICD course, when would be a good time to do that? Is that something that, I'm not on a board, I'm sort of mid-career towards getting to the end of my career. And I'm just wondering, because everyone always says what a great course it is it something that is worth doing, or is it only something really worth doing if you're thinking about being on a board or about to apply?
Look, and note that I used to be on the board, so I had a vested interest here in selling you the product. But there's a couple of hierarchies in that. There's also a Foundation of Directorships course, which is not as intensive as the actual full AICD course. But if you are thinking about a board career, if you are thinking about even running your own business, then the AICD Company Directors course is really worthwhile. So I did mine 2010. I deliberately did not do it where I lived. I did it in Canberra so that I could mix with a different group of directors, and was much more focused around some of the government aspects of that. But it was, as Gillian has said, it's a very good course. There are lots of refreshers that you can do. But if that's not, you're not ready to step into that, then there's a whole lot of other levels of things that you can do within the organisation as well.
Okay, because I suppose most of us who are in private practice, we run our own businesses as well. So would it be, I own a vascular imaging business. I mean, is it something worth doing for those of us who are in private practice?
Oh, look, I would say so, yes. I think it will give you a really good, just perhaps a more nuanced appreciation about some of the factors. Both, there's a day spent on the financials, there's a day spent on strategy, there's a day spent on risk, for example. Those things are very much the bread and butter of life in corporate entities, whether you're on the governance side of that or whether you're actually running your own business.
Are there any other questions from any of this audience? Bridget.
Thanks, Pecky. Thanks, Jill and Susan. It's such a pleasure to listen to other women who are so capable and see how their pathways have developed. Susan, I think a lot of women surgeons are over contributors in that if they see a problem, they will get in and roll up their sleeves, whether they're paid to do it, whether it's part of their formal leadership role or part of their formal role at work. So with so many different organisations that you're involved in, how do you manage your time and how do you apportion your time so that you're effective but not over contributing, and so that you're you've got a work life that is sustainable for you?
What a great question. Look, not well would be the answer. No. I've always been I won't say multitasker, because multitasker implies you can do multiple things at once, and I think all the evidence tells us that you can't. But I've always had multiple parts of a portfolio, whether that was time in the army as well as being time in surgery, whether that's working in public hospitals at the same time as you're working in private hospitals, whether that's being a mum, whether it's doing other roles. So I'm used to, I guess, role switching between things. I think the interesting thing is, if you do take on a lot of these roles, is you have to really think about your own capacity, and your capacity not just for status quo, but your capacity for when things go wrong. Because when things go wrong, you do have to be able to step away from other things. You need to be able to put yourself all in. I mean, when I had probably a good 8 to 10 months of really having to step up very big time to a very large organisation that was in crisis, it meant a lot of other things going off the side. So if you don't have the ability to be able to do that, and you can't prioritise what needs to be prioritised, then it's not the game for you. That said, sometimes, and if I go right back to the early days, sometimes when there was a crisis in one entity, it was just lovely to be going to work then after that crisis to another entity that wasn't in crisis, where it actually filled your boat and you felt like not all of the world was out of kilter. So sometimes the perspective that doing multiple things brings to the other can be quite therapeutic.
Margaret?
Yeah, thanks to both of you. Really, really interesting presentations. I was going to ask you, Gillian, about, you sound like you've been very successful in persuading colleagues to do things that perhaps they didn't at first want to do. I just wondered if you've got any tricks you can share as to what it is that you say to those people that sort of makes them reflect overnight and come back with a positive answer.
Oh, you're muted, Gillian.
Yeah, that's a good question. I think just by the first thing to do is just to be there and do what it is that you're trying to get other people to do, just to show them that it's possible, you know. So I guess when I rang these women wanting them to join the council, you know, I was already doing it, and I could explain to them what it involved and how, what a positive experience it is for them. And also, I guess it's sort of a gentle persuasion, in that I think that we all are incredibly privileged, and there is an expectation that we give back in some way. I mean, you've got, obviously, you don't want to be too, you know, sort of puritanical about this, but I don't know. I think I was sort of pleasantly surprised that so many of them did say yes. So maybe they'd been thinking about it anyway. They just needed that tap on the shoulder. That's the whole thing, that I'm sure, you know, other people felt like I did when they looked up on the podium and just saw all these guys and they realised the whole council was men. I mean, I wasn't the only one who thought like that. So, and I think the whips has helped, because we can just talk about anything we feel like, and they feel comfortable to ask questions of people that have already been there, you know. I hope that helps.
I just wanted to ask this question because you're both incredibly outstanding, and when you talk about your careers, it's incredibly impressive. And so perhaps for someone who's going to watch this later, who is, you know, wants to be a trainee or is a trainee, did you always have leadership aspirations? Was this something that, you know, all the way from sort of university days and junior doctor days, that you were always sort of doing leadership things? Or do you find that it was as you got more senior in your roles and you felt more comfortable that you suddenly started to look around and see how, and I like that circle idea, how you could change things?
I don't think I had leadership aspirations at all. And at school, I was sort of pathologically shy, and certainly didn't think about wanting to be a leader at all. And when I went to uni, I guess it was all about sort of having a good time and getting your way through medicine without failing and discovering boys. So I certainly didn't. And then I was really pretty busy. I had 4 kids in 5 years and was trying to set up a private practice, and it just didn't occur to me. I think I had this light bulb moment in 2015 when I was already, pretty senior, I guess, when I realized that somebody had to do this, that the progress that we'd made in increasing the number of women in surgery was good, but we still had a long way to go. And I thought, well, I'm the one really who, now that my kids have sort of left school, it's time that I actually did something. So no, I still have trouble seeing myself as a leader, to be honest, but I just do things that give me pleasure as well. It's not just the circle of influence. I do want to make what I do meaningful, but I also want to make it enjoyable and satisfying.
Susan?
Yeah, I think that's a really interesting question. I mean, if I look back to medical school, I was president of the Medical School Student Society or something. But I think I've been very fortunate because I got to go through the military, which has got leadership absolutely embedded in it at every level, from junior to small team leadership. But I do think if I look back, I could not have imagined where I would land with my career. I couldn't have imagined that it would be only a couple of years out of medical school that I'd be running, a United Nations healthcare facility as the only doctor looking after 350 Australian, New Zealand soldiers in a war-torn country. I mean, I just couldn't have imagined that. And I don't think that the dean would have imagined that too, because I certainly wasn't a particularly spectacular student. I have more than my fair share of 51s and a couple of supplementaries, and spent I think I hold the distinguished record for 19% or something for first year medical physics. So, look, I don't know, but I absolutely relate to what Gillian said about those light bulb moments. I think they have been very profound. If I remember one particularly where I was in a room and my mate and I were just looking around and going, well, where are all the grown-ups? And we looked at each other and went, oh, actually, we're now the grown-ups. When did that happen? We now have to step up. It's for us to make these decisions because we've reached that stage of our lives. I certainly remember another one of those moments, and it was really my first chair role. There I was the deputy chair. The chair was away. The chief executive officer resigned that day at the board meeting. We had a new director who'd just been onboarded. And I remember just sitting there and going, oh, well, where do we start? I guess it's agenda item number 1. Sometimes you don't choose these things. They choose you, or circumstances are there, and you don't have much choice but to step up to it.
Margaret, did you have another question? No, your hand's up. Does anyone else who's on have any more questions? I could just ask lots of questions all night, but that's just me. I was going to ask, this is a little bit thing, but Susan, I noticed that you've written a children's book in both English and Bahasa. Do you speak Bahasa Indonesian, or was it translated for you?
Right, there's a discussion. So I've always been a curious person, and I've always believed in whenever I take on a board role that there's a piece of education that needs to come with that. So this particular board that I took on, which was Aspen, is building a number of facilities in Indonesia, about 23 hospitals and 76 clinics across West Java. So I thought it would be a really good idea to improve my Indonesian. So I'm just in my final stages of finishing a Diploma of Arts (brackets Indonesian) at the moment. And that was my semester 1 project. So yes, I did write it. I was very privileged to have it launched by the Indonesian ambassador to Australia last year. And yeah, the second one about TB is in the works at the moment.
Fantastic. Now, Sue Lynn's got a question. Where do you both think younger leaders or those who are less experienced um, what can they do starting out, or who are starting out can do to make an impact for early leadership roles?
Well, I think there's lots of options, actually. I guess it depends on where your interests are, but even starting at the College of Surgeons, they all of these societies and surgical groups have committees or groups of the younger people that I think the people who do that are future leaders. And or you could go to somewhere like Avant, or I'm sure Mega, because they also have younger doctors groups as well. And that's a good way to, feel your way a bit. And it still can be quite influential, I think, because as an insurance company of doctors, we're very interested in the younger doctors' opinions. And yeah, I don't know what Susan thinks, but there are quite a few opportunities to use your sort of medical background, but also get involved in governance.
Yeah, I agree. Shamelessly, come to us.
No. Come to us first.
Right, that's okay. The other one would be the AMA. I was a student member of the AMA and then ultimately went on to become a member of the Federal Council, which was a fabulous opportunity. Was able to chair the Health Economics and Financing Committee of the AMA, which is where I learned so much about how hospitals don't work. And the funding models and so forth. So I think there are lots of opportunities for younger cohorts, for surgeons in training, for doctors in training, etc. And even in your communities, have a look around and see what's out there. The opportunity to be on a school board or on a not-for-profit board, that's where most directors, to be fair, cut their teeth. And you can learn such incredible skills in sitting around some of those tables. And everyone's looking for diversity these days. And it's about age diversity as much as it is about other diversity. So if you think that's something you're interested in, put your hand up, let people know that you're interested in doing it. And I suspect you'll find people who are more than happy to say, could you come and be involved?
Great. Any more questions? Well, we normally go for 90 minutes, but there is 7 minutes. I might give everybody an early mark. I just want to say thank you to both of you for joining us. And I think it's amazing the work that you have done to encourage female surgeons. And it's I was really pleased that both of you agreed to do this talk and that everyone can get the opportunity to hear from you and learn about your experiences. And it's been amazing, and you've both been fantastic. So thank you so much. Thank you for everyone who's joined us. And remember that these will be put on the Women in Surgery website, on the college website. So you can let your friends know that they should watch it. And we will see you again. We've got 4 more webinars left, and we've got, and we're hoping that the next one we might be looking at the gender gap, and talking a bit about financial issues and things that we should be thinking about as women in surgery and women who perhaps one day want to actually retire with a nice lifestyle. So it should be hopefully an interesting webinar. Anyway, thank you all so much for joining us, and good night. I hope you all have a really great evening, and I will see you at the next webinar. Thank you. Good night.
Thanks, Becky. Thanks, everyone. Bye.